I'm going to take you straight to a clinic I was working in Kenya several years ago. It was the end of the day and we were about to pack away all of our equipment and start getting ready to go home. And one of our nurses called Rosalind brought a lady to me called Fortuna. This is Fortuna here. She looked really stressed. She had a baby wrapped in a swaddle. Her clothes were ripped and she looked exhausted. And she was sat down in front of me and I examined her and I saw a familiar sight. When I looked at her eyes through the slit lamp, rather than having a clear view to the back of her eyes, she had white pupils. She had cataracts in both eyes. She was relatively young for this. She was in her late 20s. And I asked her if she remembers ever being able to see. And she said, "I think I could last see when I was about 4. So I explained that we could try and do surgery for her, but even if the surgery itself was successful, she may not see because her eye and brain had never communicated or hadn't communicated long enough. But if she was willing to try, so were we. So she agreed and we took her to the hospital. It's always mixed emotions whenever I'd see anyone with cataract. One was real excitement that it's possible that tomorrow they'll see again, but also one of a deep sense of frustration that they'd been blind for so long and they didn't need to have been. And her story isn't unique at all. She's one of 36 million people globally who are blind, and 4 in every 5 people who are blind from a curable or preventable condition. The groups who are most affected tend to be the very old. So the majority of people who are blind are in their 50s and above. However, the populations who are most affected in low and middle income countries have a very young population, lots of children. So when you look at the 2 groups who are most at risk, you've got the older age and then children who live with a lifetime of the consequences of poor vision. And when you look at where these people are, they're primarily in low and middle income countries. So this is a map that's been distorted to show where the prevalence of blindness is highest. So in sub-Saharan Africa and Asia, you can see it's swollen. If you look at where the ophthalmologists are who are providing the treatment services to them, they're predominantly in Europe and the Americas. And nowhere is that disparity between those in need and those who can provide services greater than in sub-Saharan Africa. And to give you a sense of the numbers, for every practicing ophthalmologist in Kenya, we have 100 in the UK. In Moorfields Eye Hospital, not far from here, there's over 100 practicing ophthalmologists. That's more than the whole of Kenya. In Kenya, where there's around 90, half of them are based in the capital city, Nairobi, which serves about 8% of the population. So as you start to go into the more remote parts of the country, you can have a single ophthalmologist responsible for a population of up to 5 million people. I came to know about this issue having grown up myself with severe visual impairment. So I grew up seeing a blackboard that looked like this. I didn't know it wasn't normal. My teachers would regularly say things like I was lazy, I wasn't paying attention, I was daydreaming. My colleagues here from Peak will tell you I'm still the same. But I was not aware that this was not normal. And after much persuasion and my parents saying, "Look, you should really go for an eye test," I managed to put it off for the best part of 2 years, primarily because I associated an eye test with getting glasses and looking different. I didn't associate it with seeing differently. But my mother's quite a forceful woman, and she eventually took me to the opticians, and when they put the trial lenses in, the optician was shocked at just how poor my sight was. I was severely short-sighted. And he sent me outside and he just said, "Just go to the edge of the car park and tell me what you can see." So I went and stood at the door, and I'll never forget looking across the car park and seeing that trees had leaves on them. The detail was unbelievable. I couldn't believe what I was seeing. A week or so later, I got my first pair of glasses, and on a clear night, I saw stars for the first time. And I hadn't been aware of just how much I'd missed. My education changed completely. I went from someone who was bottom of nearly every class to performing well and getting good grades. I also started to be much better at sport. And also socially, my life changed. I'd been missing out on all the basic non-verbal communication. I could suddenly see people's expressions. And it was clear that something as simple as a pair of glasses had changed the trajectory of my life forever. You can see why I was slightly reluctant to wear the glasses. So these are NHS finest pair at the time. But I became aware as well that this incredible opportunity I'd been given was not universally available. In fact, across the world, 2.5 billion people need a pair of glasses and can't access them. And I started trying to understand why this had come through an experience the same year that I got my glasses, when I was in Egypt, where both of my parents are from, and they took me to a place known as El Zebbalin, which literally translates to the rubbish people. And it's a place in Cairo where all of the waste from the city is gathered, and the smell is unbelievable. And I was just so shocked to find that people were living amongst all this waste, and their life was spent organising it. And I remember a child ran past me and stopped and looked at me, and he looked more like me than any of my peers at school did. I was the only non-Caucasian in my school, and I always felt like I was very different, but here I looked so much like this child, and yet I couldn't have been more different. The opportunities in the life I could have had in front of me could not have been of a greater gap than what was available to him. And I just felt this very deep sense of guilt, primarily, for having an incredibly fortunate life, but also one of great confusion. Why did I have what I had and he didn't have it? Eventually that guilt turned into a sense of, for whatever reason the world is the way it is, and I want to contribute something to change it. So several years later I got into medical school. I then became an ophthalmologist, and 6 months from becoming a consultant, my wife and I left our careers in the NHS and we moved to Kenya. This was a combination of eye equipment, baking equipment, and our luggage. And we also moved there with our 1-year-old son. And I was working with the London School of Hygiene and Tropical Medicine to do a PhD, but the primary purpose of the PhD was to understand the eye health needs of an entire population. I wanted to move from being able to manage an individual's eye to understand what it would take to manage a population of people. That required establishing multiple eye clinics. So in total we set up 100 temporary eye clinics, using whichever buildings we could find. So this is a local village chief's hut. We'd often use a school or a local church. Here's an example of one of the schools we set up our clinic in. This photo was taken from as close as we could get to it with the vehicle. It took us an hour and a half to carry over £100,000 worth of eye equipment just to load it into the van. Most of the places we went to had very poor or no road access. Some places were not reachable in the rainy season, but when we did get there, we had state-of-the-art hospital equipment, the type of stuff you'd expect to run in the NHS. And we were able to do really high-quality eye tests and gather data to really understand what the risks were for going blind. But almost 80 of the 100 clinics that we set up didn't have a stable power supply. One of our team, who still works with us, called Cosmas, had this incredible ability to determine whether there was electricity. So he used to take the light bulb out, lick his finger and touch it. Wouldn't recommend it. But he would rig up a petrol-powered generator and we'd run all the equipment from it. And one time the generator broke and he actually managed to invert the battery on the minibus to run all the kit, and everyone was so proud of him until the end of the day when we wanted to go home. People were less proud of him at that point. The thing that was consistent in every one of the clinics that we set up was the queues. There would often be 200 to 300 people waiting when we got there. And we'd work day and night examining them, treating them, offering them surgery. And I remember thinking that I thought I would feel good about myself now that I was doing this. But actually I felt worse. I thought, these people are only here once. There's probably more people in that same community who haven't turned up, and I'm not coming back. And so we're just scratching the surface. And I started to really understand all of the barriers that were facing people in the community. As hard as it was for us to get there, it was 10 times harder for them to come to us. And we started to break down what were the barriers to people getting the services. And a simple acronym to remember the reasons they couldn't access services were just to follow this A, B, C, D, E, F, G. So one was awareness. So many people were not aware that they could be treated. So in the same way as a child, I didn't know that I couldn't see. So many people either don't know they can't see or don't know that what they have is treatable. So for many people, going blind in old age is normal and therefore accepted. Bad services. By that I don't mean that the treatment quality isn't necessarily good, but that people will often have to queue for a long time, or there won't be somebody available at the time they go. And when you've travelled 2 to 3 days to get somewhere and there's no one there to see you, you're probably not going to try again. The costs are often prohibitive, both direct and indirect costs. So sometimes the treatment itself can't be paid for, or there's a reception charge or multiple charges as you go through the system. Or equally, the cost of leaving home for the day is just too difficult to do. The distances people have to travel, particularly given many of them are frail, are too much of a challenge to get to where you want. People forget that when you're blind, you require an escort. That escort is somebody who's usually taken out of the community as a consequence of somebody else's blindness. This is a typical example of a child who's not in school because he's now looking after his grandmother. But if you try and persuade somebody who can't see to leave a community that they've been in for many years and already are isolated, to get on a minibus and come to the hospital, they won't come on their own without somebody they trust. So if a minibus is sent without room for the escort, or there's no space in the hospital for that second person, they'll turn down the opportunity to come and get treatment. Another big one is fear. Lots of myths and concern around what will actually happen with the treatment. And finally, gender. Women are affected by all of these barriers more than men. And it was in one of these clinics that had the long queues where I went to go and use the pit latrine facilities. So this is a place that had no electricity, no road access, and no running water. And as I went to open the door, this old man came out on his little phone chatting away. And I just thought, I'm in the middle of nowhere and there's perfect mobile signal. And the signal was actually so good that on my smartphone I could do video conference calling with my PhD supervisors. And as I started to research this, more than 80% of people had access to a mobile device, but only 50% had access to clean running water or sanitation services. And although that's a shocking statistic, people had already started to realise that this connectivity could mean other things could be delivered that hadn't before. A big success story in Kenya has been M-Pesa, which literally translates as mobile money. It currently carries more than half of Kenya's GDP via mobile text messaging. It's completely transformed the financial sector. And in a very short space of time, technology has moved in a way that none of us could have imagined. So this was taken in 1968. It's a 5 megabyte hard drive. 1 year later, this computer, which was bigger than this room, was the computer that put a man on the moon. The first iPhone that came out more than 12 years ago was 300 times more powerful than that computer. And just 2 years ago, a $10 Android smartphone came out that was more powerful than that first iPhone. So things have moved in a way that is hard to believe was possible. We're connected in a way that we never have been. We have computational power that we've never had, but equally there's this huge unmet need. And that was the inspiration for Peak, to try and take down these barriers that people were facing. And so with an amazing team, we started building new ways of delivering the tests that required complex equipment and highly skilled personnel to do it. And the first thing we did was the vision test. We needed to be able to accurately measure vision in the hands of non-clinical workers. And so I'm just going to do a quick vision test on everyone in the room. So if you're wearing glasses, please take them off. I'll also be offering free surgery at the end for anyone who thinks. I'm a bit rusty. So here, this looks like a letter E. The legs are pointing that way, so I want you to point in the direction that you see it. And you'll see it starts to change direction and get smaller. There we go. I'm looking to see who can't see. There's a couple of people struggling now. There we go, very good. And that was the principle on which we built this test. So the whole idea was we wanted to create a test that was not dependent on language, because often an eye test tests your literacy as well as your ability to see. We wanted to make sure we were just measuring your vision. and also to make it more objective than a normal vision test. So on a standard Snellen chart, the examiner actually has to do quite a lot of complex thought processes, including knowing which letter to point to, when to progress or stop the test, often end up giving people clues, like, are you sure? The charts get very dirty. They'll often have lots of biro dots, the ones that we'd see on them. And if you were sneaky, like I was at school because I didn't want to fail the test, I'd learn it on the way in. So I didn't want to fail the test. So this test makes it possible for anyone to accurately measure vision without clinical training. And we've been able to demonstrate this in the hands of school leavers, community volunteers, and we did this through a process of gathering lots of data against the PhD study that I was running. And at one point, when we tested about 300 people who had been tested both on the big standard chart by an ophthalmic nurse and on the smartphone, 2/3 of the data looked exactly, it was correlating perfectly with the data that we were getting from standard tests, but 1/3 just looked like nonsense. And I couldn't really understand why. So on the subsequent round of tests, we started tapping into every part of the phone to get as much data as we could. And most of your smartphones will have multiple sensors on them. One's a front-facing camera, one's a proximity sensor, and the other is measuring the ambient light in the room to adjust your screen brightness to save battery on the phone and optimize your screen. So we started measuring how bright the room was every single time we did a vision test to measure something called lux. What that allowed us to do was look at the quality of the results taken on the app versus the other one, as well as bringing this other factor. And what we could soon see is if you went above 900, that was when the results didn't make sense. And so our hypothesis was that reflections on the screen were making it difficult for people to see, and that was why we weren't getting good results. So I asked the team to make sure they always tested people indoors or in the shade, and they said, yep, no problem, Dr. Andrew, we'll do that. And then the next 300 sets of results came in. I ran the analysis, and it was exactly the same. So I thought, I can't understand what's going on here. So I went with the team, door to door, and what I discovered was we were basically trying to adapt the environment to fit the test. But in fact, what we should have done was make the test fit the environment, because most people's houses didn't have a room that was 3 meters long. So we adapted the algorithm, rather than being a 3-meter test, to be a 2-meter test, at which point more than 95% of people could do it indoors and we were getting an accurate test. We used the front-facing camera to use a bit of basic Pythagoras to make sure we were the right distance, but it didn't work very well. We tried using standard objects like asking people to hold money up. People didn't really like holding money up and having a photo taken for some reason. We tried using an echo bounce to make sure we were the right distance. That didn't work very well. But then we came up with a really clever technical solution, which was a pre-cut piece of string, which was incredibly effective at making sure we were the right distance. But we soon learned there's only so much you can do within an app. Here's a classic example of a mother having her eye test and her daughter telling her the answers. Things like that you can't control in a smartphone. And so we learned the limitations of what it could do, but also the basic training required to deliver it effectively. And we ran a study whereby we put it in the hands of school leavers and non-healthcare workers, and we'd have them test people at home and then the next day in the clinic, so that we could get a measure of repeatability. If I test you today and tomorrow, I'd expect the same result. We did the same with a Snellen chart, the clinical standard test, and then in the clinic they had the gold standard test. And what we were able to find was it was as accurate as the gold standard, it was more repeatable than Snellen, and it was quicker than both. And we published that data several years ago in JAMA. So at this point we knew we had a way of identifying if people could not see. But the next challenge was trying to determine why they couldn't see. And so we started wanting to be able to look at the retina. So many of you will be familiar with the retina. So this is the optic nerve, a direct extension of the brain. And you can see more about the whole human body through the eye than anywhere else. However, it's a bit of a dark art, and it's often known in the profession as a guessing stick, so the ophthalmoscope. And I remember very clearly as a junior doctor, my neurologist trainee saying, "You want to be an ophthalmologist, come and examine this patient," and he'd just kind of heroically been lying on top of the bed examining this patient. And I got up and I thought, I'm sure I can see something. What I realised I'd seen was my own retina, because I'd spent a minute shining the light in my own eye. So I have complete sympathy with any non-ophthalmologist who doesn't know what they're looking at when it comes to looking at a retina. And so the alternative is we have these great cameras which can take stunning images of the back of the eye, but their limitation is they require stable power supply, they're not designed to move, they require infrastructure. And so over a period of years we developed multiple prototypes, and the first time we got one to really work was when the use of 3D printing had kicked in, and we were able to prototype much more quickly. And this version was designed to fit over a Samsung smartphone, and it would take the flash from the phone, redirect it to be in line with the camera to give you the effect of an ophthalmoscope. And here's my long-suffering wife's retina, which has been examined with every single prototype over a number of years. So every time I came home with eye drops, she knew a new prototype was ready. But the key was not if it worked in my hands, but would it work in the hands of a non-clinical worker. And so we did the same as we did with the vision test. We put it in the hands of general nurses, school leavers, and we ran a study which included over 2,000 people, in which they would examine their optic nerve using a smartphone. They would also be examined on the standard camera, and all of the images were sent to Moorfields Eye Hospital to be independently graded. And we found for optic nerve assessment, they were comparable. And we published that data a few years ago also. But the work we were doing was actually never about making tests. It was all about people like Fortuna who couldn't access basic services. And although these tests could help us find who they were or what the problem was, it didn't mean they were getting treatment. And I was working with a brilliant ophthalmologist called Dr. Rono, who's pictured here. And he was helping me as I ran this program in Kenya. And he said, I wonder if there's a way of helping. I work in this place called Qatar Lee, and I started to learn more about where he worked, and his story had really inspired me in that he'd lost his father when he was young. He was sponsored by someone in Scotland to go to school, only went to school when he was kind of 9 or 10, but did extremely well. Managed to get into medical school, and whilst at medical school found loads of people had eye problems and no one knew what to do about it. So he decided he wanted to become an ophthalmologist. He trained as an ophthalmologist, came top in East Africa in the training scheme, and when he finished, the Ministry of Health basically said, look, where in Nairobi do you want to work? And he said, I don't, I want to work in Qatar Lee. And they said, but there's no eye hospital there. He said, yeah, no, I'll make one. And he has. So 10 years later, it now serves a population of close to 3 million people. And in that district, there are lots of schools. And he said, there are loads of these children in these schools who can't see. Now, I knew this to be true from my own personal experience. And what he had been doing was sending a nurse from his already very busy clinic to the schools to go and examine them. And when she did, she would find 5 to 10% with a significant vision problem that was going to affect them for the rest of their lives. But most of her time was spent examining normal children. And the clinic was already overrun, so he couldn't justify continuing to send her. Equally, he didn't want to know that there was all of these children out there that he could do nothing for. So we thought, well, we've built this test, why don't we see if teachers can do it? And so we started training teachers to deliver the vision test. And one of the really interesting things was, A, they were great at doing the test, but they would always ask, what does this mean? You know, the results show 660 or 2040, what does that mean? We'd even heard a story of a child getting told off by their parents for doing badly on their eye exam. And so we realised we needed a non-medical way, a visual way of explaining this visual information. And so we built a simulator that showed the visual world of the child in real time to the teacher as soon as they'd done the test based on the score they just got. And they instantly understood what was going on for that child. So they went from being this child who was considered ignorant and lazy to someone who can't see, and this is what they could see if they were treated. So rather than being sent to the back of the class, which would normally happen if you weren't paying attention, which would only make your problem worse, they were brought to the front of the class, and the teacher cared about them getting treatment. And I'll always remember this brilliant teacher in one of the schools who we were working with, who I went to meet him and said, oh, you're the English teacher. And he said, no, I'm Kenyan, a teacher of English. And here he is delivering the test. And one of the things that we discovered, partly just because it was on a smartphone, children were really excited about doing it. but also because no one, including the teacher, knew if he was passing or failing, didn't feel stigmatised in front of his peers. Because no one likes to fail a test in front of their peers. It was why I avoided doing the test for so long. Equally, we built in additional things, because if a child said they couldn't see and would shake their head, we made it possible that you shake the phone to record that they couldn't see. And it would just vibrate to tell you the test is finished and then show the teacher the visual world of that child. But we soon realised that the child and the teacher are not the decision maker, it's the parents. So we needed to influence the parents. And so we took a little Bluetooth printer, and that same image, we created a photographic version of it with some basic referral information for them to take home in their school bag. And later I'll explain why it was important for it to be a colour picture. Any child that hadn't passed the test, the teacher would be given a prompt to put in more information about the child's parents, their name, and their contact phone number and language. It'd take them about 30 seconds to do it, and as soon as they click save, it would automate a personal text message to the parents. So the parents would get this message saying, your son, by their name, was examined in this school, was found to have this problem, and they need to go to this hospital. We also realised the head teacher had a lot of influence in terms of making sure people got care. It turns out head teachers are quite competitive. You see the rather large trophy on the desk. So one of the things we tried was sending kind of motivational messages. And the thing that was most effective was actually telling the head teacher how their school was doing compared to neighbouring schools in terms of the number of people needing treatment who were actually getting it. And one teacher actually arranged a minibus and filled up with about 30 children and brought them straight to the hospital the day we sent the message. And I was there with Rono in the hospital and suddenly all these children came. And we found ways of being able to very quickly educate a whole school about the process. In the same way I had all of you guys doing the eye test, we were able to do that in the community. So here you can see a whole group learning, and this boy here is like me, so you can tell he can't see, he's copying his friends. But we would sensitise the whole school, and then we'd go and deliver the screening test. And we ran it as a randomised controlled trial in which 21,000 children were screened, and 900 were identified with a visual impairment, and that was delivered by 25 teachers in just 9 days. And when we did that, we realised we had a potentially scalable solution. That programme in Kenya has now gone on to provide services to more than 200,000 children. But the key ingredient was not just that we were identifying the children who had a problem, knowing that there was a service for them, but we were tracking whether or not they reached the service. And so we have this closed loop system. So you've gone from finding people to referring them, and what we'd found in practice is of those who'd been referred, only 10 to 20% of people would normally turn up. And when we put this system in place, we were able to track how many had been identified, which was giving us a measure of the prevalence, how many had turned up at the service, which was giving us a measure of adherence to referral, but we're also getting a feedback loop in terms of the quality of the referral. So how many of those people should have been referred or not referred in the first place gave us information about improving the training for those who are doing the screening. And what we showed in our trial is that we nearly tripled the adherence by using PEAK compared to normal card-based vision tests and a referral letter. And that data was published earlier this year in the Lancet Global Health. That same principle was then used in Botswana. But in Botswana, it was a slightly different challenge in that it's a huge landmass, and there's huge open spaces, and the distances between the services are even greater than in Kenya. And just to give you a sense of how different that is, the same population in Kenya sits in a space 22 times the size in Botswana. And so the gap between those needing services and the service is even greater. So there we tried something different. Rather than screen everyone and then send them to the hospital, we'd screen about 10 to 15 schools, and then we'd bring all of those people to a hub point and then send services from the hospital to them. So an outreach type model. And again, we could then build this same feedback loop. So how many had we found? How many turned up for diagnosis? And some would receive basic treatment at that point, and then how many would get referred for the service. And in Kenya, we'd gone from, when I say nearly tripled, it'd gone from about 20% to 55% adhering to referral. In Botswana, it was closer to 95%. And this is one of the hubs. This photo was sent to me by Ryan, who's sat over there, panicking. I was really excited because it had worked. He was terrified because it had worked. And suddenly all of loads of people had turned up, and there was a lot of people to treat. We used the same model again in India, but in India we went one step further, and of those who'd received a service, we then went and examined them 3 to 4 months later, unannounced, to see what had happened. So what was the impact, what was the outcome of the treatment that they'd received. And what it allowed us to do was start generating data points across the whole system. So we could start to see the patient journey and the barriers that they were facing and what might be done to do it. And now, the reason this is so important is if you can't see something, it's very hard to change it. And in public health, as in many things, we put various things in and we have an expectation of what's going to come out the other side. The reality is often different. But what happens is we just tend to put more stuff in or something different in, expecting a different reality. But it usually doesn't happen, and the time frame between different projects and programs is often so big that we don't learn the lessons from the first time. And it's because systems are leaky. Health systems in particular lose people all along the way because of these barriers. And so what we wanted to do was identify where these barriers were in the system. So was it because people were being referred but not turning up? Or is it that they were turning up but the treatment wasn't working? For example, in India, we found that of those who'd received glasses, only 50% were wearing them 3 months later. Now that was really important because you can think you're having the impact that you want, but unless you track them all the way through, you don't know. So we knew there was a challenge there in terms of acceptability of wearing glasses in that context. Through our dashboard, it's possible to see all of this happening. So here in Kenya, the grey schools are ones that are planned to visit. Blue are ones where screening has happened. Green is when treatment's been delivered. You can click on any one school to get detailed information. And you can track people through this live dashboard, seeing how many have been found, and start at a population level, seeing them move through the system, including what type of treatment they've had. And we're now working on new ways of visualising that health service pathway to see where the barriers are and the outcomes and blockers in there, with the view that we want to strengthen the system. And the reason it's so important is if you don't know where the barriers are, if you can't see them, you can't do anything about it and you can't improve it. And just to give you some specific examples, so we talked about these different barriers here. One that we faced a lot was fear. Prior to moving to Kenya, I spent some time working in Sierra Leone, and we were offering surgery to people in an outreach clinic, and they kept saying to me, I don't want to come because I know what you're going to do. You're going to take my eye out and replace it with the eye of a cat. And I heard this several times, and had it been only once, I would have maybe ignored it, because so many people had said it, I thought there must be something in what they're saying. But I had no intention to replace their eye with the eye of a cat, and neither would I have known how to. But as I started looking at the post-operative patients in the hospital, their visual results were excellent, but because of the technique being used, their pupil was slightly peaked. So it did actually look a bit like a cat's eye. So if you look just at the hospital data, their visual outcomes were great and they were performing well, they were meeting all the standards. But as a consequence of the cosmetic appearance, more people were staying blind than were being treated. So unless you're able to zoom out and take a full health system approach, you miss these things that result in what you think is a positive impact, you're actually potentially causing harm. A specific example in Kenya was we were offering free transport and free surgery to people that we found. And the team would counsel the patients who we'd found, offering them surgery. And as they were going through it, I just suddenly always see their face drop. And I started to realise it's whenever they use the term supaswaji. And I said, what do you mean by that word? And they said, to operate, to do surgery. I just wondered why they always look so stressed about it. And then I heard the same word used in a totally different context. And I asked someone, what do you mean by that word? And they said, it means to butcher or to split. And so there actually wasn't a word in the local language for surgery. And so what these people were hearing was, I'm going to offer you free transport and free butchery on your eye. And was it it was no surprise that they didn't want to take it. So just by changing the word, so to be clear, no mobile application is going to do that, but it helped us pinpoint the barrier. But just changing that word increased the number of people who accepted coming for surgery. And in one of the villages we worked in, I met this brilliant lady. She was so sweet. She insisted on force feeding us corn and making us tea. And she just had such a lovely face that I was so shocked that on her wall she had this poster of Rambo. And I would quite often see in people's homes these colour photographs on the walls. And they're often of very random things, but people treasured these images. And that was the inspiration that we used in the school programme for creating these images. And when we first did it, we would do images of the back of their eye or of their eye, but we realised they had no real connection to that. So we just started taking portrait photos with some basic information of where they needed to contact if they had a problem, and we'd give them it. And it doubled the number of people who were being offered free surgery. If they were given a photo, they were twice as likely to turn up at the hospital we were working in, just because of this intervention. And that's why we started using it in the trial. And over time, we've been able to use the data that we're gathering through this health system approach to advocate for change at a policy level. And recently in Botswana, the Minister of Health and the Minister of Education, and more recently the President, have agreed to adopt a programme in which every single school child in the whole country will be screened and treated. And President Masisi came to London earlier this year to advocate for eye health at the Commonwealth Heads of Government meeting, on the back of which 53 heads of government have now prioritised eye care as something that they will pay attention to and make a commitment to track their progress at every heads of government meeting. So data can be incredibly valuable to push for change. As well as our programme with children, we're also doing similar work in the community. So we're in the midst of a programme in both Pakistan, but now also a trial in Kenya, where we're going door to door to deliver screening and encouraging people to come to a primary eye care centre, so that we can understand, again, the barriers to people coming from all the way out in the community through to the primary eye care services and through to the hospital. And what this allows us to do is track where they are, understand their, who they are so they're contactable and traceable, and also to make sure that we link them to a key informant, so like a head teacher, somebody who can bring them together. One of the things that we learned when I was living there was sending a text message to somebody who was blind actually wasn't very helpful. But if they were associated with somebody else who had a phone and was responsible for them in the community, that person could bring people together and arrange transport or so on. Now, what I didn't tell you is, although this was true, it took close to 2 years of preparation to make that bit possible. And that's the difficult bit. So what everyone wants is the nice pictures of people being tested on smartphones, and the vast number of people coming through a system very quickly. And although it's true it does happen, the work that goes before it is actually the really clever work, the really hard work. And our process is to go through really understanding, is there a need in the population? Are there people that have a problem that can be treated? And is there the provision there to treat them? So who are the eye care providers? Are there the hospitals, the optometrists, the primary eye care clinics? And who else is in that ecosystem? Who are all of the stakeholders who have a say as to whether or not someone will go through this system? Who are the people that will support it? Who are the people that will block it? So we often spend months in meetings and planning to try and align everyone around this pathway so that ultimately we can come up with a plan that delivers this mass change across the system. And having done this for several years, we've learnt that this is a very long, hard process that is built on relationships and trust, nothing to do with technology. And if we want to do this at the scale that is required, we'll either have to become a huge organisation or we'll do it through partnerships. And so we've taken a decision a couple of years ago to align ourselves with NGO partners and governments who have a shared mission. And we're now working with a fantastic organisation who are over 110 years old, CBM International, one of the biggest disability charities in the world, who deliver eye care programmes across 30 countries. And this year we've started working with them in Zimbabwe, Rwanda, Pakistan and Indonesia, with a view that over the next several years we will start to expand across all of their areas that we're working and beyond. And all of this has been made possible by a dynamic, mission-led, incredible team who I couldn't be more proud of. And everyone has come from completely different backgrounds. So we've got people who've got public health training, we've got people who are from the business world, people who have come from a kind of corporate background, an NGO background, but we've all come together to deliver a change that we believe can happen. And the way we've structured our organisation to make sure we can deliver this mission is as a hybrid social enterprise. So we spun out from the London School of Hygiene and Tropical Medicine in 2015 as a UK charity, the Peak Vision Foundation. And a couple of weeks later, we set up Peak Vision Limited, which is the company that's 100% owned by the charity. And the reason we did that was any company's ultimate purpose is to increase the value for its shareholders. So what that normally means is raising as much money as you can so that your shareholders benefit. But we wanted our shareholders to be Fortuna, and Fortuna couldn't pay. So that's why we structured it in this way, so that every single decision we ever took would be based on who it was we were trying to serve. Now that poses us with challenges because there's potentially other places we could work which would generate more income for the organisation. And the organisation, so the subsidiary company is building all the products and services, and it's largely funded through grants, charitable grants and donations that come through to the foundation. This year is the first year we've started generating real income through the company by providing our services to government partners and to NGO partners. And we're hoping in the next 2 to 3 years that just through the services we're delivering to our partners, the company will become sustainable to continue doing more and more of it. And any profits that we generate are returned to the foundation for it to make its own grants to people like Dr. Rono, who are providing incredible services. And so we end up having, through this model, a system that pulls people in to services and a way of supporting those who are delivering the services to make more and more of it happen. So that people like Fortuna can be found before it's too late. The next day when we did her surgery, we all felt like that it was going to be unlikely that it would work. But when we took her eye patch off, we were shocked to see that instantly this huge smile grew on her face. And what would normally happen is people would stare at me, the Mzungo in the room, but she didn't. She was only interested in her 6-month-old baby who she'd never seen wrapped in a swaddle, and she was just absorbing her face. And she said, "I'm desperate to go home because I've got 2 other older children whom I've never seen." So we took her back with everyone else that we'd brought from that area to the clinic where we'd examined her. And when we got there, we parked the minibus and everyone scattered off home, and she just stood there. We said, why are you not going home? She said, "Well, I actually don't know where I live." I said, "Well, how come?" She said, "Well, I heard a rumour that there was an eye clinic, and I travelled for 9 hours to find you. And that's why I came at the end of the day. And I nearly got run over on the main road, but all I was told was there's a big white sign by the main road and I must cross there." So that was all we had to go on to try and find where she lived. So we spent 3 hours driving up and down the road until we eventually found, well, there was lots of white signs, but we found somebody that knew her. She said, "Oh, it's Fortuna, the blind lady. What are you doing?" She said, "Oh, I can see." And she said, "Oh, well, you know, you live in this direction, you need to go interior." So we started this long walk, and the longer we walked, the more people, particularly children, started following us, until we eventually got to the edge of the village and she knew she was nearly home, and then she just stopped. And she said to one of our team, said, "I'm scared." I said, what are you scared of? And she said, "Well, what if my husband's ugly?" So we didn't have a solution for that. But she bravely went on, and as she got to her home, her husband came out the back carrying a little chicken, and there's all of these children everywhere, and she just stared at them and said, "Which of these children are mine?" And then her 2 children came forward and embraced her, and this is the family happily reunited. And that's why we do what we do. Thank you.
And I think we have expressed our gratitude by giving the medal, and thank you very much again.
Thank you.
You've been on your feet for a long time. Come and sit down, please. would like to express the gratitude of the Royal Photographic Society, the Medical Awards Committee, and my personal gratitude as well to the Royal College of Physicians, and particularly for their hospitality tonight. Andrew Goddard has left. Would you please, Simon, express our gratitude to your college for their hospitality, and we look forward to further collaboration between the Royal College of Physicians and the Royal Photographic Society. I would also like to thank Royal College of Surgeons, Royal College of Obstetrics and Gynecology, Royal College of Ophthalmologists, Royal College of Psychiatrists for their collaboration on this combined Royal College medal. I would also like to thank Anton for videoing the lecture, and of course I must also thank Angelos Rentis, the photographer for Moorfield Eye Hospital. He's more or less now in-house photographer for the medical group. Thank you very much. Now, one huge thank you to a very important person without whom this event would not take place. This event has been taking on an annual basis, and this particular person is also involved in the logistics of the main awards night, which is on the 29th, which is the premier Oscar night of the Royal Photographic Society. She does all the logistics for that, and she's a very, very hard-working person. My gratitude to Joe McDonald. Please give her a big hand. Joe, like last year, we wanted to give you a bouquet of flowers, but the budget is tight. Ladies and gentlemen, thank you for turning up tonight, and I wish you a good night, safe journey home. Thank you.